going to clinically improve. Everything need to be assessed in a proper manner if you want to tackle this pancreatitis. So briefly about this, what is this? And what are the various myths that we are supposed to know about pancreatitis is? I mean, doesn't mean that always you should remember that any pathology in the pancreas doesn't mean it's only because of alcohol. It can be because of multiple other events also. And always it predominantly because of multiple autolytic activation, because of the enzyme formation which is going to happen, and cytokine storm. As we all know, most of the infections because of the cytokine storm, this pancreatitis is going to be there. And antibiotics, is whether the antibiotics is having any role, is there or not, and somatostatin analogs are various things which is being useful, and what is the role of Ulinastatin as of now which is going on, and what are the various interventions which is being happening in the field of pancreatitis once the patient develops multiple other complications. These are all the various areas. This is my area of disclosure to discuss with you all today. So about pancreatitis, it's nothing but any inflammatory process which is going to happen in the pancreas. As you all know that the pancreas will be taking care of exocrine as well as endocrine functions. Exocrine function will be taking almost around 80% of the role, and remaining endocrine function will be taking care of almost around 20% of the role will be there. And if the patient is going to have pancreatitis, the clinical presentation is very characteristic, the clinical symptoms is very characteristic, and the patient will be having more of stabbing type of pain, predominantly in the epigastrium, and sometimes the pain will be radiating to the back, and the patient will be presenting with multiple signs like equivalent sign, greater sign, other system involvement, hypertension, shock, various organ failures if the patient is going to be present. There are multiple things that I'll be discussing in my upcoming slides. If you want to discuss about this pancreas, the pancreatic enzyme, so much of exocrine activity, pancreatic enzyme which is being secreted is going to release into the duodenal lumen. And once if it is going to be, release, predominant release prior to that, once the trypsin is going to get activated, and once the trypsin is not going to be denatured on its own, so what is going to happen? The hot road digestion, the so many other processes, the compartmentalization, everything is going to get distorted, followed by the inflammatory cascade is going to get set in, and PAMP and DAMP activities is going to get established, and which will predispose to pancreatitis. So if you want to discuss about this pancreas, always you should remember the golden period, first 72 hours, followed by within a period of week, followed by in second week, in third week, and followed by in fourth week, how the patient is going to evolve with this kind of complications. And always the pancreatitis will always sometimes will be a acute onset presentation. Sometimes if this kind of pancreas is going to have recurrent inflammation, and followed by the patient is going to have exocrine insufficiency like steatoria and other complications, followed by imaging changes, so much of calcifications. Once the patient is going to develop any, along with the pancreatic duct dilatation, there are so many other things which will predispose to chronic pancreatitis. And one more entity before switching into the main area, that like recurrent acute pancreatitis. Also, we should not remember if the patient is going to present with recurrent episodes of pancreas, doesn't mean that the patient is having evidence of pancreatic duct dilatation or other process. The patient will be presenting only with pancreatitis. So what do you mean by this pancreatic type of pain? There's typical epigastric pain. And if you're going to work up this patient, you'll be having enzymatic elevation. The enzymatic elevation like amylase and lipase, which is both sensitive and around 2 to 3 times of the upper limits of the normal. And by imaging wise, you are going to pick up the finding like peripancreatic fluid collections, edematous pancreas, so many other things to be discussed in the definition for pancreatitis. And if you're going to look into the severity, there are so many things to be discussed that we'll be discussing in my upcoming slides. How will you classify this pancreatitis? It's nothing but interstitial pancreatitis, which is a less of complications. And once the patient is being evolving into that, once the infection and other things is going to set in this process, the patient can go for a necrotizing pancreatitis, which is almost around 10 to 20% of the case reports are being there. So globally, there are so many cases of being there, and many of the patients are being reported. In South India, there is a study which is being done on 2012 to 2018, which being reported an incidence almost around 13 to 14% of the cases rise are being there. And always, if you're going to look into the etiology of pancreatitis, doesn't mean that is only because of alcohol, doesn't mean that is only because of gallstones. See, always you should remember alcohol and gallstones will be the predominant etiology. Gallstones pancreatitis is nothing but biliary pancreatitis. So if the patient, so in India, in CMC value and multiple centers, they have been tried even because of gallstones. There are around 30 to 40% of the cases of pancreatitis mainly because of gallstones. And if you're going to look into alcohol, around 20 to 30% will be because of alcohol. And always you should remember that when you're going to do any intervention for the patient, like ERCP, if the patient is going to have acute biliary obstruction, the patient is going to present with choledocholitis, so many other presentations. So when you're going to do ERCP, what is going to happen? So the patient can develop ERCP-related pancreatitis, and multiple toxins, as we are well known, even multiple envenomation, as we are well known, multiple drug-induced causes for pancreatitis, even genetic causes for pancreatitis. There's a huge list of causes for pancreatitis. Always we should remember, if you couldn't able to come to the conclusion only because of alcohol or gallstones, we need to work up the etiology for pancreatitis, whether anything is there to supervene. So briefly about the physiology before switching over the main area of discussion. So the pancreas, the exocrine part of the pancreas is going to secrete the multiple enzymes, and it should be going to release into the duodenal lumen. If you are going to look into the functional unit of the pancreas, is nothing but the acinar cells. The acinar cells is going to be, and then all these things is going to activate in one form of zymogens, what is going to be activated. So once this trypsinogen is going to get converted into trypsin, this predominant pathway is going to be initiated. So what are the various things that once the trypsinogen gets converted into trypsin, all the enzyme activation will be there and be releasing into the duodenal lumen, like chymotrypsin, elastase, phospholipase, and carboxypeptidase is going to be there. And if you're, what are the various protective measures which is happening in your pancreatic system to prevent this pancreatitis? You all should remember that the pancreatic microcirculation is well established, and pancreatic microcirculation will always prevent the inflammatory cascade, and it will always prevent the ARDS and other major organ dysfunction setting. So what are the various protective measures which is being there? Means nothing but compartmentalization, which means, as you are discussed now, the acinar cells, which encloses zymogen granules, will be all arranged in a compartment, on all the digestive enzymes is going to be stored in that, and remote activation. So what is this remote activation? Suppose if the digestive enzyme are secreted, because these enzymes are going to predominantly secrete it as an inactive form, it will prevent this premature activation. If it gets prematurely activated, what is going to happen? The patient can go for multiple other pathology, multiple other complications, catalytic process, and so many other things. As we all know that the protease inhibitors, like the trypsin inhibitors, the trypsin is one of the major pathways which is going to be initiated. The trypsin inhibitors is secreted along with these proenzymes to suppress any premature enzyme activation. So what is going to happen if the premature enzyme activation is going to happen? Auto shut off. So which means the trypsin itself is going to destroy its own trypsin in high concentration. Now, so you all know that, see, suppose if you're going to look into that, a low calcium concentration in the cytosol, which always also promotes this degranulation of the various systems, and there are so many things being involved as a protective measures in pancreatitis. So if there is any acinar cell injury because of any toxins or envenomations or alcohol or biliary pancreatitis, if the injury to acinar cells is going to happen, what is going to form? The premature enzyme activation is going to set in. The premature enzyme activation will fail the protective, all the protective mechanisms is going to get failed down. So what is going to happen? Once the protective mechanism is going to get failed down, there's a huge cascade of pancreatitis. The initial phase, the intermediate phase, and the late phase of pancreatitis is going to set it. So what is the initial phase? The auto-digestion of pancreatic tissue, which will predispose to local insufficiency, vascular insufficiency. So you have been seeing so many patients with pancreatitis. Sometimes we'll be treating in the ward. Some patients will be admitting in the intensive care. We don't know what is the reason. See, the pancreas can involve any organ system, will go for multi-organ dysfunction. So that is the area to take care of, because there is no single medication still proven much benefit to have a significant effect, because it's only a conservative line of care in the malignant acute pancreatitis. But because if you're not going to treat your severe acute pancreatitis in the right proportion, and if the patient is going to develop organ failure for more than 48 to 72 hours, which means the patient's mortality definitely is going to be more than 50 to 60%, that we are not supposed to forget. So we need to take care of the patient. We need to bring down the patient. We need to take care of all the major effects which is going to set in. We need to take care of the cytokine storms to set in. All these things to be prevented within the first 72 hours. That's a major important thing for make the patient to survive, at least to make the patient to give a life at least. That's the most important area for us as a gastroenterologist to take care of. So it will predispose to vascular insufficiency, WBC activation, and multiple pathways are being releasing, and cytokine toxicity and release of various enzymes into the circulation will be predisposing to organ failure, as well as to local complications like pseudocyst, wall-of necrosis, so many other pancreatic complications to set in. See, this is an outline about the pathophysiology, that what's the enzyme activation being, so much of other pro-enzyme activation, that's what been discussed. See, if the prekallikrein, like age-band factor, phospholipase, what's going to happen? So prekallikrein activates the kinase system, age-band factor is going to activate your clotting system. So that's why some patients can predispose to thrombosis and other signs of inflammation, that what you're going to see as Cullen's, as well as if you're going to see as great tunnels, and sometimes Fox signs, so many things, so many external markers is there to diagnose pancreatitis. One of the very interesting interesting entity to deal with that in the clinical presentation. So if the patient is going to have phospholipase activation, triglyceride activation, so hypercalcemia, the patient can predispose to metabolic complications, the patient can predispose to shock and other things, and also all because of the pro-inflammatory mediators, which is going to set it. So if you're going to remember about the pathogenesis, the main thing is mainly because of the pancreatic injury, which will predispose to edema and inflammation. The second effect is going to produce a ileus-like complications, retroperitoneal edema, followed by the systemic complications, depends upon your mild or moderate severity, or in case severe presentation like shock and other things. So if you want to grade the severity, multiple scales of the multiple scoring system, being the like BISAB, so many Ransons, Apache, so many scoring systems are there. But Atlanta criteria from 2012 has been checked into account. There's a modified criteria of Atlanta in which we are being categorizing as mild acute pancreatitis or moderately severe or severe acute pancreatitis. So mild acute means that doesn't mean the patient will have only epigastric pain, but the patient will not be presenting with any organ failure. The patient will not be having any multiple complications with the minimal enzyme elevation. So what is that moderately severe pancreatitis, which means the patient can go for organ failure, but organ failure, at least with 1 or 2 vasopressors, we are going to improve that within a period of 48 hours. The patient's systemic symptoms are going to improve without much evidence of local complications. Local complications like peripancreatic necrosis, fluid collections, and abscess developing, all those things. This is nothing but the moderate to severe. And severe acute pancreatitis means if your organ failure, even with inotrope support, if the organ failure, if it is going to last for more than 48 hours, which means the potency for that patient to go for high mortality, around approximately 50%, is still very high, and which will predispose to multi-organ dysfunction syndrome. So usually, so what is this phase? The cytokine activation, that's what I've been discussed, followed by, see, if you're going to look into any septicemia process, the first thing you should remember that SARS. SARS is nothing but a systemic inflammation. This is what I discussed in the previous slide. So this, I'll be coming to this slide later. So if you want to discuss like SARS, what is going to happen if you're going to look into that? SARS is nothing but a temperature elevation, or first thing it's because of temperature variant, or if the heart rate is going higher down, or if the respiratory rate is going higher down, if the background of fever, in the background of high WBC count or low WBC count with band shift. So all these things to be taken into account, at least 2 criteria to be taken if you want to say the patient is having SARS. If the patient is having SARS, then the patient can go for sepsis. SARS, sepsis, severe sepsis, septic shock, organ dysfunction, followed by multi-organ dysfunction, then the patient is going for death. So we want to prevent this cascade to set in. We want to save the life of the patient by preventing this cascade to set in. This is the most important for us to deal with. So if you're going to look into this interesting scoring system that will be frequently using in ICU in the management of severe acute pancreatitis, is nothing but a modified Marshall scoring. There are so much of scoring system, bedside index, like BISAB, so many things are there. So for example, bedside index, I will tell you, what is it? BISAB is nothing but blood urea nitrogen has to be elevated and impaired mental status and age criteria, and along with your pleural effusion, all those things to be taken care of, taken into account if you want to say BISAB scoring, along with serum creatinine also. So if you want to say all these elevations and Apache scoring and the Ransom's criteria, so many things, but organ failure assessment will be taking care of this ARDS, which is nothing but the respiratory PaO2 by FaO2 ratio. And we, based upon this, if it is more than 300, has to be made in a successful way. If it is going down, the organ failure process is very high, respiratory failure sets in, and renal failure, hepatic, cardiovascular, hematological, and neurological parameters, all these things to be taken into account if you want to say this patient is having evidence of organ failure. So this is about the etiology, and this is about the image of pancreatitis, like peripancreatic fluid collection with pancreatic necrosis, so many things. And one mnemonic, very interesting thing I would like to say, one saying, what is nothing but the idioms like, it always drinks like a fish, the patient will go for dehydration. The patient usually it will burrow like a rodent, can produce a fistula and other complications. It will sting like a scorpion, will predispose to severe pain abdomen. That is the most common entity for which the patient is going to present to you in the casualty. And next to that, the patient will kills like a leopard, will always be a life-threatening. It eats like a wolf, will be predisposed to multiple complications like necrosis and peripancreatic fluid collections and other things to set in. So this is what I've been discussing about the organ, SARS and other criteria. And so we need to take care of this organ failure to prevent mainly see most common complications. Always you should remember the organ failure, the patient can go for ARDS because the pulmonary, I mean, if you're going to look into the microcirculation, the pancreatic microcirculation will always be co-linked with the alveolar microcirculation. So the pulmonary interstitium, once a patient inflammatory cascade is going to set in, the patient can develop followed by the patient can develop ARDS. Once the patient PaO to by FaO ratio is going to get altered. So these things, acute lung injury, ARDS, can happen if the patient is having severe acute pancreatitis. So this is the various immunological cascade in case of severe acute pancreatitis, where the role of Ulinastatin to some extent has been proven beneficial. That's the area for us to discuss right now. But apart from that, see, there is a multiple hit process by the first hit and second hit. So what is going to happen? The proenzyme activation and along with your intestinal ischemia, your reperfusion injury. So all these things will be predisposed to neutrophil, neutrophil segregation, the selectin process activation, the ECAM, I mean, extracellular addition molecules, the LCAM, the VCAM, the vascular cell addition molecules, all these things is going to be activated, which will predispose to multiple lymphoid activation. It can predispose to systemic targets, it can predispose to respiratory targets, and it will predispose to multiple enzyme elevations, as in as injury, trypsinogen to trypsin activation, all these things, along with your intestinal bacterial overload, endotoxemia, all this cascade is going to set in a severe inflammatory response syndrome. That's the most important immunological cascade to discuss in the management of acute pancreatitis. So how should this homeostasis is unbalanced in severe acute pancreatitis mainly by increase your coagulation, the procoagulant process, everything is going to be activated and the inflammation is going to set in and the fibrinolysis is going to be inhibited. The fibrin formation is going to set in, which will predispose to procoagulant activity as it is with you, the cytokine storm. Now you should remember cytokine storm is even not only for COVID, it will be there even for pancreatitis. It doesn't mean, so sometimes even the various infections, we all know that mumps and others viral infections can predispose to pancreatitis also, but there are some case reports are there even with COVID-19, some patients have been presented with pancreatitis also, but isolated COVID-19 pancreatitis, we are not very sure and still more paper need to be validated. Apart from that, cytokine storm, which will predispose to coagulation injuries, shock and lung injuries, cell death, immune paralysis, and respiratory renal failure, finally organ dysfunction and complete death process is going to set in this case of cytokine storm because of the proenzyme activation in the management of acute pancreatitis. So the most important entity for us to discuss is the management process. So management of mild pancreatitis is nothing much. So we are going to manage in a conservative way. Probably we may admit the patient, and once the patient been hospitalized, we'll do the conservative line of care. Probably most of the patients will improve on its own. And we need to look for the triggers, we need to eliminate the source, we need to eat for the etiology, what is the reason for the acute pancreatitis to set in. So always we need to categorize the patient, whether the patient is presenting with evidence of mild or moderate or severe pancreatitis. So if the patient is going for severe pancreatitis, as you are assessed by the BP, alteration of BP, if the hypertension, systemic hypertension is going to come down, if your urine output is not going to be set in, if your creatinine is going to raise, along with your respiratory hemodynamics insufficiency, PaO to FaO to ratio alteration, all these things will be taken care of. Your severe acute pancreatitis followed by, once these things is going to set in, always the patient needs to be hospitalized, the patient should be in ICU care, and we need to give inotrops or other support based upon the clinical presence and other things, how it is going to establish. This is the complete acronym, what is called as pancreas. It's very well known right from basic surgical books and basic medical books. These have been given right from your MBBS. You'll be knowing all these things, but to brush up what's happening before coming into the main area of discussion, like pancreas, if you're going to look into the acronym, the management is mainly because of pain relief. We need to take care of the pain. We need to put the patient on analgesic support. That's the most important thing. And next to that, the patient deserves intensive care admission or not. That's the thing. And next to that, now the nutrition status, whether the patient is going to for intubation or followed by oxygen support or nutrition support, everything has to be taken care. And pancreas is mainly because of a CVP line, whether it is needed or not. And most of the because this is very old guideline, but even then I'm just giving a clear-cut statement. Nowadays the CVP line is not being much used, but what we are going to use in ICU care to assess the volume, fluid overload, other status that I'll be discussing with you when I'm coming for that slide. So we need to see the rehydration, and we need to assess the endotracheal bin, whether the patient deserves intubation or other things. And apart from that, whether the patient deserves any antacid support, and based upon the CVP monitoring like Spangans, steroid support in case of ARDS, all these things, like this is a whole nutshell in the management of severe acute pancreatitis has to be taken care of account, and clearly we need to delineate that. So vitals monitoring, CVP monitoring. Always you should remember, if the patient been hospitalized in ICU, we need to do a complete blood count, we need to do a LFT, we need to do a basic viral marker screening, and we need to do a basic amylase and other things. We need to do a lipase, and all these things has to be taken care of. Routine RFT and other parameters, a baseline X-ray chest and abdomen has to be taken care of, because X-ray abdomen will will diagnose most of the patient who is having multiple complications. One X-ray abdomen will identify whether the patient is having ileus or other coexisting pathology. So most importantly, X-ray abdomen, it's an important thing if the patient is going to present with severe epigastric pain, unless and otherwise proved, even if it is not pancreatitis, always X-ray abdomen to be taken to confirm whether it is not because of pancreatitis or not. Apart from that, so ABG monitoring, all these things, calcium, magnesium, metabolic profile, lipid profile to be taken care into account. So ACG 2000 guidelines, what they've been say. Always you should remember, if you want to start the treatment for pancreatitis, the patient will be in pain, you need to put the patient analgesic support, the patient will be dehydrated, we need to take care of IV fluids, the patient will be having poor nutrition area, and the patient's nutrition has to be taken care of to prevent the catabolic process, to prevent the pathogen pattern to be activated, to prevent the microbial pattern, to prevent the bacterial translocation. All these things we need to start on early nutrition support. And apart from that, we need to take care whether the patient is antibiotic or other thing, and so many other areas that I'll be discussing. So the first thing, IV hydration. So we take care of IV hydration because most of the patients will be dehydrated. Some patients will be vomiting. Some patients will be having third spacing loss, and some patients will be having increased respiratory loss. So many things. The patient will be diaphoretic. The patient will be tachypneic. So we don't know what's the reason. We'll be assessing them. So we need to take care of the early aggressive IV hydration is most important thing. But this is what, as per the 2013 statement, but now as per the multiple guidelines, what I've been thinking, this early aggressive IV hydration is no more in use. But what can we do, can be done if you want to manage a patient with acute pancreatitis? We need to do serial IV fluids management. So how do you do this? Sequential IV fluids management is mainly because of, first we need to see what is the fluid loss. So if the fluid loss is, suppose if the fluid loss is too high, followed by, first we need to assess the fluid loss, and next to that we need to see what is the type of fluid we are going to use, and we need to assess whether the response is good or not. This is the other three things you should remember if you want to take care of fluid loss. So in the management of acute pancreatitis, what is the fluid loss? This is by Ransom et al. Statement. There are multiple very old trials, and what they have mentioned, the fluid loss at predominantly at 48 hours, it will be around 3.7 to 5.6 liters. That's what been documented. And Madry et al., what they've been telling, approximately 3.2, but some studies can go up to 6 to 7 liters, also been documented. This is approximate fluid loss, and this fluid loss, the various predictors what can be used, like younger age or presentation. If you're an alcoholic, it may vary, and glucose, if you're hypoglycemic, if you're a diabetic and other complications, that may vary, and if the patient is having organ dysfunction, SARS, it may vary. So basically we need to see what is the fluid loss, which will be approximately 3.5 and 3.7 to 5.6 liters in mild to moderate pancreatitis. So what is the predominant fluid you are going to use? Always you should remember the predominant fluid, what is going to recommend is always crystalloids or colloids. In crystalloids, normal saline, or it could be ringer lactate. In among these crystalloids, what is the thing which you're going to prefer to always ringer lactate? That's the main thing to be taken care of. It's very well known, but why ringer lactate? Always to prevent, because normal chloremic, to prevent normochloremic acidosis. Because if you're going to use normal saline, there is high possibility for the patients to develop a normochloremic acidosis. To prevent that, the ringer lactate is always well documented. And also if the patient is having low calcium concentration, hypocalcemia, in the acinocyl injury, what's going to happen? Then patients can go for acidosis and other processes to set in. All these things in order to prevent, the ringer lactate is a predominant thing. There are so many strands, so many studies have been proven, and I don't want to discuss each and everything, but you always should remember ringer lactate can be tried. But how much of fluids we can do? If you want to treat the patient aggressively, you can go up to 4.5 liters per day. Or if you don't want to be very aggressive, you can give up to 3.5 liters per day. And there are so many other populations. These are so many trials being proven recently in 2013, what they've been done. 15 to 20 ml per kg of bolus followed by 1.5 to 3 ml per kg per hour of maintenance fluid can be taken care. See, all this fluid management is the most important. The first 24 hours followed by 24 to 48 hours followed by 48 to 70 hours. The first 3 days is the most important period for the fluid management. The first day, that was the most important day. The first day has to be taken care, has to be taken care in account properly. So after 24 hours, once the patient be treated for 24 hours, after 24 hours, if you want to treat the patient with IV fluids and other support, so what you're supposed to do, So we can give up to 1.5 ml per kg per hour. And there are two groups of patients have been, in this study, they are taken into account. In the first group, what they've been done, they are given up to 1.5 ml per kg per hour for the first 24 hours. And followed by the second group, they are given a bolus of 20 ml per kg, followed by 3 ml per kg per hour, what they've been given for the next 24 hours. So, followed by in 30 ml per kg for next 24 hours they've been given. So in all these studies, what they've been identified, that doesn't mean the much of defect. It doesn't going to have much of response in preventing the necrotic complications, in preventing the SARS, and all these things. What I've been mentioning in that, no need to go for early aggressive hydration as with the Dutch and other groups of members. What they've been assessed. So we need to start the fluid maintenance of around almost a bolus of around 3 to 4 liters in the initial day. That's more than suffice to manage a patient with acute pancreatitis. So fluid management is the most important thing. And next to that, most of the patients will be in pain on day one. So the pain management, definitely because of vagal, sympathetic and parasympathetic, all these things has to be taken into account to prevent other complications, to prevent the cardiovascular, other thing effects. So always you need to take care of your analgesia. So what is the predominant analgesic thing we can use? NSAID, well known, and opiates. Opiates is always well preferred rather than NSAIDs in the management of acute pancreatitis. If you want to take, just a minute. So if you want to take about this analgesia, so main thing we can go for NSAIDs, or also we can go for opiates. So if you want to go for the NSAIDs, the predominant thing what you're going to use diclofenac. When you're going to use the NSAID, always you should remember whether you're going to have a renal failure, whether the patient's having any paralytic ileus or any other complication also to be taken care. But when you're going to use opiates, the problem is if the patient is having respiratory insufficiency, or if the patient is having any other tolerance, we need to see whether the patient is having any other complications. In this study, what they've been saying, they have been taken diclofenac and pentazocine, and followed by over a period of every 8-hourly interval, along with they added a bolus of fentanyl as a rescue analgesia. What they've been tried, they've proven that, see in this study, what they've been mentioned that the pentazocine group is having a significant benefit when compared to, which means the fortwin group is having a significant benefit when compared to the NSAIDs group. So the preferred analgesia is always opiates, always we need to take care of the pain, followed by we can give paracetamol or other things once the patient pain gets settled down. But the initial phase, either opiates or diclo, or if this is having no response, we can add on to that, provided we need to monitor other complications, whether it is there or not. So this is about the analgesic effect. So we need to take care of the pain, we need to take care of the IV fluids. And next to that, what is the antibiotics? Is there any role for antibiotics? So what's the study? Most of the study, they were mentioned, there is no much of role for antibiotics support in the initial phase, in the first 40 to 72 hours. But always we should remember, even if you're not going to start the patient's antibiotics, suppose sometimes if the patient, unless and otherwise, if the patient is not going to land up with multiple organ dysfunction or organs, systemic complications, always we can wait in the initiation of pancreatitis. And moreover, if you want to do a imaging also, CT scan is not recommended in the initial phase, only ultrasound guidance is more than enough. CT, unless and otherwise, only when the patient is having suspected cholangitis or any other presentation, or if the patient is worsening, or if you're suspecting any peripancreatic fluid collections, like that kind of condition only, like that kind of scenario only, we need to do a CT scan. Other things not needed in the initial attempt. And ERCP in pancreatitis also, always you should remember that it's not, first 40 to 72 hours, no need to intervene at any point of time, unless and otherwise if the patient is going to present with the evidence of severe cholangitis, which means the fever is going to be high, the patient's shields and dry is going to be set in, along with the patient will be having elevated total count, CRP, procalcitonin, everything is going to be high. If the patient is having evidence of cholangitis, then the patients, you can initiate within 24 to 48 hours, you can do an ERCP in emergency setting. Apart from that, there is no role for ERCP also in the first 24 to 42 hours. So the rational use of antibiotics in the initial phase is not much of role, but there are some studies, what I mentioned, even in the initial phase you can try, but if the patient is having like extraperitoneal infections, that what I've been discussed, like bacteremias, UTI, pneumonia, or coexisting cholangitis, all these things we can try. And initial phase, the role of antibiotic is not much of it's not much of a benefit. And apart from that, some studies have been mentioned, early antibiotics, some studies in the Japanese population, some studies what they mentioned at less than 70 hours, there is some proven trial in the randomized trial paper what they mentioned, there is some reasonable benefit to prevent the cytokine storm and other things, but a significant beneficial role with the prophylactic antibiotic has not been documented much. So once the patient is going for necrotizing, the fluid collections, other complications, once the patient is going to set in, then at that point of time, you can initiate the patient with antibiotic support, but not in the early phase. So about the nutritional process? So what about the nutrition? So these are all very important in day one. So we need to take care of the nutrition. See, always the first 1,000 calories is the most important thing to be given every day. If the patient wants, see, because 90% of the population will be nil by oral at the time of admission. So you're not going to put the patient on feed at initial phase of admission because they may be having pain, they may be in shock, other complications. So we need to see when to initiate the patient with nutrition. So once the pain gets settled down, mild to moderate pancreatitis, definitely we can initiate the oral nutrition as early as possible, and followed by, but if the patient is moderate to severe, once the organ dysfunction, all those things is going to improve, then at that point of juncture, within a period of 40 to 72 hours, we can initiate the patient with the enteral feeding support. Enteral feeding, it could be either because of the NJ type of feeding, nasojejunal, or it could be because of nasogastric. Nasogastric feeding, if nothing but right tube, is very easily available in many centers. Easily you can access to that. But NJ tube feeding, what is the problem? Will not be available easily. And next to that, if you want to plan NJ tube feeding, because NG tube is very difficult to tolerate for most of the patients, and NJ tube is very easy to tolerate and will be aiding the digestion. So that's the most important thing when compared to NG or NJ. NJ is most preferred than NG, but you can use both tubes as per multiple trials is being going on. Apart from that, the nutrition, what is the nutrition you are going to take care? At least 1,000 calories in the initial phase. That's the most important thing. And it should be a polymeric compound, and you need to take care of 25 to 30 kilocalories per kg per day. The nutrition, the caloric value has to be there, and 1.2 to 2 grams of protein of caloric value has to be there. So this is a part of the nutrition. So nutrition, either, and the role of total parental nutrition is not much high, and total parental nutrition is not definitely indicated unless and otherwise if the patient is extremely very ill, if the patient is terminally moribund, if the patient is shocked, and if the patient is having neurological complications. Apart from that, usually the role of TPN is not much beneficial, and moreover not being used in multiple centers. And so early enteral nutrition, definitely what is going to happen, they'll be improving the gut mucosal barrier, prevent disruption, and it prevents the translocation of bacteria, and also it prevents prevents the formation of pancreatic necrosis and other complications to set in. So this is about the basic thing. So nutrition part, antibiotic, analgesic, along with IV fluid, the initial thing has to be taken care in a proper manner. And suppose if the patient is having severe acute pancreatitis, so there is some role, see, because since there are multiple papers being quoted that there are some evidence of Ulinastatin can be tried in the management of severe acute pancreatitis, even if the patient is having evidence of organ failure, other things. So always you should remember the protease inhibitor. So what is this Ulinastatin? It's nothing but a urinary trypsin inhibitor, which is predominantly non-specific, and it's a Acute type of serine protease, which is predominantly involved in that. So it's a multivalent compound. So what is this Ulinastatin? Is nothing but it suppresses various proteases like trypsin, plasma neutrophil, elastase, chymotrypsin, and also it will be predominantly stabilizing your lysosomal and cellular membranes. You all remember that Ulinastatin now being used for multiple things, even for COVID phenomena, even for organ dysfunction, even for ischemic insufficiency. All these conditions can be tried in Ulinastatin, but our role in this, so it's inhibit the formation of lipopolysaccharide activity and inhibits the release of inflammatory features and removing oxygen. It also suppresses the oxygen-derived free radicals, and it is going to improve microcirculation and tissue perfusion, and it is going to improve endothelial injury. So all this role is definitely being there if you're going to use Ulinastatin, but still no much of papers, excellent papers to validate that. But even then, if no much of molecule, since acute pancreatitis in the setting of severe acute pancreatitis, but I am seeing in multiple centers where they're using nowadays this kind of drug, but to quote that, very few papers are being there to support, but even then, at least, so something is better than nothing. We need to try with this, and always you need to suppress the inflammatory activities. You see, what's the main thing? See, how the Ulinastatin is going to, and that's what been discussed. So this excessive level of interleukins, chain of alpha activity, and all these things will be downgraded, and the egress of neutrophils will be downgraded, and endogenous protease inhibitors and elastase activation, everything is going to be downgraded. All these things to be taken care of account if you're going to use this Ulinastatin. So always you should remember the predominant etiology like toxins, the precipitating factor like alcohol or any gallstone pancreatitis, which will predispose to acute pancreatitis. What is going to happen? Which will predispose to cytokine storm. So TNF, interleukins, everything is going to be released. So once the cytokine storm is going to set in, what's going to happen? It's going to activate the lymphocyte process like ICAM, intercellular activation molecule, ECAM, extracellular adhesion molecule, ELM, all these things followed by, it will egress neutrophil followed by the leukocyte adhesion is going to develop. Once the patient is going to develop the leukocyte adhesion, which will predispose to multiple biochemical injury and multiple coagulation injury, all these things which will predispose to endothelial damage and perivascular edema and multi-organ dysfunction, and all these things has been is going to develop with the patient in the process of pancreatitis evolution. And with Ulinastatin, a urinary trypsin inhibitor, which shows a significant effect in suppressing this activity. So this is how it is going to be involving to prevent the formation of ARDS and also inhibit the formation of prothrombotic activity. So fibrinolysis, microvascular coagulopathy, all these things going to be get suppressed if you're going to subject the patient with Ulinastatin and other things. So the trypsin premature activation, the coenzyme activation, the cellular injury process, all these things to be taken care of account by Ulinastatin. So if at all in the management of acute pancreatitis, but once the patient is going to be in severe acute pancreatitis, there is some potential role for this Ulinastatin that you can consider in the management process. So this is how it's going to happen to prevent the premature activation of all these enzymes. So amplification process will be initiated. So the trypsinogen, chymotrypsin, all these enzymes, premature activation will be getting inhibited if you're going to use this Ulinastatin. There are multiple papers and multiple trials are there to support, but even then, strong recommendations still more need to be validated if you're going to use in the setting of acute pancreatitis. But one paper to support the use of Ulinastatin, this efficacy and safety of intravenous Ulinastatin versus placebo, what been tried in this study. So if you're going to use Ulinastatin, there will be a significant benefit, definitely is going, but the side effects is very less because you're going to use only for 3 to 5 days. Very few patients can develop nausea, vomiting, and diarrhea, but usually it will be uncommon. Injection site reactions are very uncommon. So since it's biological and obtained from human urine, so manufacturing follows all these things, the validated virus is being produced. So all these things to be taken care into account, but this is about the safety of Ulinastatin in clinical setting by Abraham et al. In Association Physicians of India, what they've been discussed. So how to administer this Ulinastatin? So I'll be preferring around 1 to 2 lakhs, depends upon the clinical scenario, and I'll be giving for 3 to 5 days. I can give around 2 doses. Some patients I may go for 3 doses also, and predominantly I'll be going for 5 days. Most of the patients, if the patient's having evidence of severe acute pancreatitis, so we can mix the formula in either normal saline or 5% dextrose, and you need to infuse the content over a period of 1 hour of time. So this is how we are going to use in case of acute pancreatitis. Also, it'll be using in other scenarios like vascular insufficiency, COVID, and other complications. That it's not my area for interest to discuss. Apart from that, so this is how we are going to manage the inflammation. This is how we need to take care of the nutrition, or this is how we need to take care of the primary pathology. That's what's happening in the first week, followed by in the second week, what are you going to do? We need to take care of the nutrition. We need to see whether the patient is going for organ failure, whether the organ failure is persisting or not, or whether the patient is having good nutrition support is going on or not. So always you should remember the nutrition has to be around 1,500 to 2,000 kilocalories has to be maintained every day. Whether the fluid collection is developing or not, do a CT. This area, if the patient is having evidence of organ dysfunction, if the patient is having infection and other things is being persisting, there is a potential role for you to think about CT scan. A CT scan can be identified whether the patient is having evidence of, see, if you're going to look into the Atlanta criteria, the most important thing, it could be, you need to categorize if the patient presents to you with less than 4 weeks of onset, if the patient is going to present with more than 4 weeks of onset. If the patient is going to present less than 4 weeks, it could be acute sterile collections, or it could be acute peripancreatic fluid collection, followed by the patient is going to present more than 4 weeks of onset. It could be because of a necrotizing, or it could be because of walled off pancreatic necrosis. So all these things to be taken care of account. See, we need to see whether the patient is having necrotizing of WOP and walled off pancreatic necrosis. All these things by imaging finding that what we are going to recognize. So what is the necrotizing? It's nothing but if you're necrotizing events, if it is going to be more than 30% of your pancreatic pathology tissue is going to be involved as per Balthazar's scoring system. So based upon that, more than 30% of the involvement of the pancreas is going to be necrosed. There's been a high possibility for the patient to go for necrotizing pancreatitis. So see whether the patient is having persistent organ failure, which carries high mortality, fluid collections, whether the patient developing any infections. How to assess fever, tachycardia, high volume, and in total counts, everything is going high. And apart from that, with the patient deserve antibiotics or not, how do you going to manage the fluid collections? That's the other things to be taken care of account. And apart from that, nutrition is the most important battle to be taken care of. That's what I've been discussed. Around 1,500 to 2,000 kilocalories of diet is the most important thing to be taken care of. The nutrition process has to be well maintained. And these kind of scenarios, sometimes what will happen the second and third week, and I would like to discuss, there are some queries for, and what they've been asking about whether the patient is having biliary pancreatitis or alcoholic pancreatitis, how will you recognize in the first few days? See, always you should remember, if the patient is having evidence of alcoholic pancreatitis, you remember that you do a baseline LFT. If the patient, within 24 to 48 hours of admission, if the patient is coming to you, if your baseline LFT is very high, if the baseline LFT, suppose for example, the enzyme elevation around 200 to 300 range, so with a mild around 2 to 3 to bilirubin, so if there's a minimal baseline elevation, always you need to suspect first possibility is a biliary pancreatitis, which means a gallstone pancreatitis, because alcoholic pancreatitis will not be presenting most of the time in the initial phase with the evidence of acute liver enzyme elevations, because biliary pancreatitis, that's a high possibility for you to concern. So this single LFT parameter will be discussing. Suppose even if you are not having any stones, always you should remember, if you're going to do ultrasound, doesn't mean that the stones will be bigger, because always you should remember there are microlithia, it means the stone size, if it is going to be less than 2 millimeter, in that case we need to use a endosonogram to identify the Charlie Sky pattern. All those things is there or not, but if the patient is having microlithiasis, in that scenario also there will be a predominant LFT elevation. So in the first 24 to 48 hours, if the patient is having evidence of amylase elevation, in the background of pancreatitis, in the background of LFT elevation, always you need to think whether the patient is presenting to with evidence of acute biliary pancreatitis. So in the second week, we need to take care of the nutrition, and we need to target around 1,500 to 2,000 kilocalories diet, and we need to see whether the patient is having any fluid. So always the concern is whether the infection is continuing, whether the infection is developing at this point of time, whether the patient now needs antibiotics, whether the patient is going for necrotizing, whether the patient is having any evidence of any infection which is being persisting, or how to manage the fluid collections and other infections. That's the most important thing to be taken care. And very importantly, the fluid collections, I will tell you in a brief way. So we need to see whether it's sterile fluid collections. So how to analyze whether the patient doesn't have any major thing, the patient fever, septicemia, shock, and other things is going to improve well down. The patient, the imaging wise, doesn't show any, only a sterile, a pseudocyst, a sterile fluid collection will be there. So if the patient is always sterile fluid, if you're going to be in second and third week, don't go for any intervention. Always go for a conservative treatment. Only when the patient is symptomatic, only when the patient worsens, when the patient develops SIRS and other complications, when the patient is toxic, at that point of juncture, you need to intervene. Apart from that, drainage is only in symptomatic patients, not in asymptomatic patients, if the patient is being there in the second and third week of event. So how to assess the severity, how to assess the means, two factors to be taken care of the natural cause. One is because of the necrosis. We need to see whether the patient's pancreas is being more than 30% necrosed, and see the size of the cyst. If it is going more than 5 to 6 centimeters, it's likely to persist. So at that point of juncture, you need to intervene. So at that point of juncture also, we need to think whether the patient deserves drain, or we can still wait conservatively. So there are multiple papers to quote that. So even for the conservative management, definitely we can think about that. See, in this trial, what they've been taken into account around a RATIONALE paper, on 40 patients, they have been chosen for a sterile fluid collections. In that, they are initiated with the conservative treatment, and another patient with the catheter drainage. So what they've been assessed in the conservative group, the 55% required drainage. Even for the conservative group, 55% required drainage. But in this 55% infected in catheter, over 55% of patients are being infected in the catheter group. So in the conservative group, 45% no intervention required, but 100% of intervention required in the catheter group. So what they've been mentioned, so if you're being catheterized, if you the high possibility for the patient to go for further infection, and the 59% of the patients following drainage. That's why always if the patients have sterile fluid collection in the initial phase, that is the take-home messages in the initial phase, definitely we can wait, watch, and monitor with the conservative line of care, taking care of nutrition and other things. So in this scenario, suppose for example, if the fever is still persisting, if the counts are going very high, if the patient CRP is going very high, if the patient procalcitonin is going very high, in this scenario, if the patient is having evidence of likely necrotizing pancreatitis, the CT shows evidence of more than 30% of involvement. So if the fever persisting, so always in this scenario, what are you going? We need to suspect a necrotic collections. So if there is any necrotic collection, what are you going to do? We need to drain or not. There are some papers to support, even if the patients have necrotic collections in the second and third week, we can always wait and watch, because percutaneous endoscopic drainage, if you are going to look in IAP guidelines 2013, percutaneous endoscopic drainage or necrosectomy, so always we can delay it after 4 weeks, because you will be seeing that after 4 weeks the patient will be go for walled off. So if the tissue of the pancreatic area is going to get walled off, means walled off pancreatic necrosis is very easy to intervene at that point of juncture. So don't do early intervention if the patient is having encapsulated lesions. So that's the most important thing to be taken care into account. Apart from that, so that's why if the patient is having worsening of TLC, total leukocyte count, it's we need to start the patient an antibiotic. We need to continue the antibiotic. Which antibiotic? Always you need to take care of gram positive and negative with anaerobic support. Some patients see the multi-resistant organisms can develop, and always you need to initiate with higher generation. We'll be using piperacillin tazobactam, or some patients cephalosporin sulbactam. All these things can be tried. Pseudomonas coverage well, but if this not going to respond, sometimes imipenem and other broader antibiotics can be considered. Sometimes even this will not respond. Sometimes chikicycline or colistin, some things should be added, but always you should remember antibiotics. You need to take care of renal and other complications. So always based upon your local culture and sensitivity, but doesn't mean that you need to take a culture from the cyst and other things, but local, based upon your local culture and sensitivity pattern can be assessed. How do you manage to decide the management of acute pancreatitis? So if you're going to look into this RCT paper, so what they mentioned in that, suppose they have been categorized a patient in 369 patients, they have done this study in the early group and in the standard group. So they have gone for a drainage procedures, and some patients have gone for a necrosectomy. So what they mentioned in that, so necrosectomy in the early group for 28 patients, and the standard group around 52% of the patients have been taken, but the same hospital stay, the same mortality, the same organ dysfunction, all those things. So in the second and third week, if the patient doesn't show the evidence of much symptoms, always is better to wait and watch rather than intervening at this point of juncture. So in summary about the second and third week of management, we need to see the waiting ICU support, see whether the patient is having organ dysfunction, nutritional care, and whether the patient deserves a percutaneous drain or endoscopic management, whether the patient deserves all those things or not to be taken care in the second week or third week. So now the problem, if it is going to be persisting even after that, fever, other things, the fourth week of illness, the fever is persisting, total counts are going high, CRP is high, procalcitonin is high, but there is no much of evidence of organ dysfunction. This is proven evidence of suspected necrosis, infected necrosis is going to happen. So we need to wait, whether we need to wait for wall of necrosis to set it. But in this scenario also, whether two situations, we can go for percutaneous drain or without percutaneous drain. The two scenarios we can take into account. So if you want to place a percutaneous, see, this is an interesting paper what they've been taken from Molly et al. So what they've been discussed in this, a conservative, even beyond the fourth week, conservative with percutaneous, with the necrosectomy. So necrosectomy is very difficult procedure. Moreover, it should be in expertise center to be carried out. And if you're going for a catheter, 70% can go in the conservative treatment. What they've been tried, 64% of the patients still having success, even if the patient presenting you with fourth week of onset. Some patients will be seeing only the fourth week. So always we should see that, see through that the patient is going to be in a conservative or an advanced line of care. So 70% of the patients will be doing good with the conservative catheter drainage itself. And in this study, only 26% of the patient deserve necrosectomy, and the mortality for these patients also will be gone up to around 12%. So this is an interesting paper from AAG. So what have been published in that? So the conservative treatment, what is the initial phase if the patient is going to present with the infected pancreatic necrosis? The conservative treatment itself is the most important thing. Followed by we can place a percutaneous drain. Followed by if you're going needed means we can go for a minimally invasive necrosectomy. There are two trials for that for this necrosectomy. One is tension trial, and apart from that, MISA trial is very interesting area. So nothing more to discuss in this scenario, but even in this, the death composites, everything endoscopic as well as surgical intervention, the death ratio around 9 to 6 will be halted in this kind. So there are two trials in which they've been taken care by a necrosectomy process. And if there is any peripancreatic fluid collection which is going to be away from your stomach, what is going to happen? Always you need to place a PCD, percutaneous drain for these cases, followed by you can go for percutaneous endoscopic necrosectomy. So even if the infected collections outside your tract, And always you should remember that even if you do all these things, doesn't mean that the pancreas is having only this problem. So pancreas can present with multiple other complications. It can present with metabolic abnormalities, it can present with UGA bleed, it can present with aneurysm, it can present with so many other complications for that. And always some patients can develop a compartmental syndrome like intra-abdominal hypertension can develop in the management during fluid and other things to be in the management process. And some patients can develop hemorrhage, some patients can develop intestine fistula, and some patients can develop infected ascites. So if intestine fistula, if other things have been done, we need to dilate the tract, other complications, we need to assess all these things to be taken care of properly. But if you're going for a cystic management, if the patient is having a lot of pancreatic necrosis, the ideal thing, what autotaxic placement can be considered as per the multiple trials, even some patients are being, in some case reports are being there. And if you are going for the stent placement, ideally you can use either plastic stent or metallic stent placement. If you are going for a metallic stent, we need to do a proper gastric lavage. We need to do so nowadays that's the most important thing. And see, if you are going for a plastic stent, what is the problem is we need to dilate the tract, and then through the endoscope we need to go into the tract, and then we need to do a gastric lavage, and then we need to assess the patient. But if you are going to place a metallic stent through this, infected cavity, so it is very easy for you to get into the tract. That's the one most important entity to be discussed. So all these problems to be taken care if you want to manage a patient with acute pancreatitis around 4 weeks to 6 weeks of presentation. That's the most important thing. And always the precision in this is we need to target the systemic inflammation, that what I've been discussed with you. We need to take care of Ulinastatin, IV fluids, and nutrition, other things to be taken care, rational use of antibiotics. And more things I want to say that there are some studies are being role of antifungal also to be considered if the patient is having persistent infection. Always you need to look for the fungal culture and other things. Based upon that, whether the patient deserves a Casper fungi or whether the patient deserves amphotericin. Based upon that, all these things to be taken care. And when you're managing these kind of scenarios, you should not forget the multi-drug resistant infections, because if once a patient persistent infection, necrotizing pancreatitis, even if you're drained, even if you're some patients can persist to have fever, now the more papers, more case reports, but it's out of scope right now for this area of presentation. So there are multiple papers are there to prove that the multi-drug resistant infections being developing. And always we need to take care, we need to see based upon the local culture and sensitivity pattern, which is antibiotic, what choice of antibiotic is the preferred one to use, and no need to drain every collection. That's a take-home message. See the patient, which week of presentation, see the size of the lesion, and see the common presenting factor, see whether the patient is having alarming symptoms, like whether the patient deserves early intervention or not, or whether the patient's conservative management is itself is enough or not. Based upon all these things to be taken care if you want to manage this patient with pancreatitis. So always the take-home message, pancreatitis, main thing, the pancreas acronym to be taken into account, the fluid management, nutrition process, antibiotic guidelines, antifungal guidelines, along with that, when to intervene the patient for ERCP, even if the patient doesn't deserve all these things. If the patient, see, cholecystectomy, early cholecystectomy, and so in the same admission, because surgical point I didn't discuss much here, always you need to go for in the same admission, once a patient in mild to moderate pancreatitis, before the patient gets discharged, always you need to consider the patient for cholecystectomy and other things. And if the patient is having evidence of no need to do ERCP, if the patient doesn't deserve any major problem, and role of Ulinastatin definitely is being taking care of and taking into account to be considered. But even then, not much of papers to being reported, but Ulinastatin definitely having an anti-inflammatory role, anti-cascading activity. Apart from that, along with multiple inflammation process and neutrophil aggression process, all these things to be taken care of. Ulinastatin also, along with there are multiple multiple protease inhibitors like mafacimab. So many drugs are being tried, and see if there is no other evidences to be in the initial phase in the MODS to be managed. Definitely we can consider Ulinastatin in the management of acute pancreatitis, because there are so many trials being discussed to multiple drugs. There is no single drug which will be proven efficacious in the management of acute pancreatitis always. So we can consider also that. Along with that, take care of the patient in which week it's falling down, the deserving any acute collections or fluid collections, or whatever the thing which is going to be presented. All these things to be taken care of, account, nutrition, other things, and followed by look for the various complications, look for the metabolic abnormalities, see that lipid profile, the hypertriglyceridemia, look for evidence of recurrent pancreatitis. And if you're going to do a plastic stent and other procedures, you need to do a 2 or 3 step procedures, all these things. So regular follow-up is the most important thing to deserve to to take to tackle this acute pancreatitis in an effective manner. So avoid alcohol, screen yourself, prevent obesity, control your diabetes to take care of this all these major complications. Because once a multi-organ dysfunction, the hypertension, diabetes, all these comorbidities will be rampant. That's a major thing which will predispose to cytokine storm. All this needs to be controlled in a proper manner to tackle these complications effectively. And with this, I would like to rest my presentation and thanking you all for your patient listening. And if there is any question, I'm happy to take over.
Yeah, thank you. Thanks a lot, Dr. Arun, for such elaborated presentation and covering almost all the aspects of pancreatitis. There are a lot of comments there in the chat box, and all of them are praising your talk. It was so nice and lucid. There is a question from Dr. Kanan Natarajan. So he has asked about, according to your view and perception, how about the incidence and prevalence of the acute pancreatitis among the uncontrolled diabetic patients and associated comorbid with mixed lipidemia? If so, then what should be the preventive care as a part of the primary prevention in the context?
So the main thing what I've been
And he has
discussing.
also added a supplementary question. Yeah, sorry, just let me finish on the supplementary question. How often the pancreatic hormonal assay should be monitored in type 2 DM?
Thank you, Dr. Kannan, sir, for your valuable question. Say the most important thing in the management of acute pancreatitis, the type 2 diabetes, see always in which age the patient is going to fall. And apart from that, mostly if the patient is acute pancreatitis, the common presentation like diabetes will not be there. Once the patient is going for chronic pancreatitis and other complications, in that scenario, because there is a exocrine insufficiency along with endocrine insufficiency, for these kind of patients can have diabetes and other complications. So in this kind of presentation, if the patient is going to have diabetes and other complications, we need to strictly control the diabetes. Along with that, insulin support is to be augmented because the patient will be ICU care most of the time, and lipids is to be strongly assessed, because if the hypertriglyceridemia is there, the patient will be having severe acute pancreatitis. So most of the time the triglyceride level will be around thousands. So we need to control the triglycerides. We need to bring down with the control molecule. And we in this kind, if the patient is having chronic diabetes and other things, so sometimes if the patient is having chronic pancreatitis, the pancreatic enzyme replacement therapy, all other modalities can be tried to manage this kind of presentation. And what's the next question, sir?
So it has a supplemented question as well, that is there any hormonal assay or anything you want to check, especially
So there are multiple pancreatic function tests is there, but there are also certain cost issues, still more constraints. Apart from that, once the patient is developing exocrine insufficiency in the form of steatorrhea, in the form of the patient is having fatty stools, which is going to be more than 7 grams, if the patient is having exocrine insufficiency, at that point of juncture, if the patient is going to have weight loss, nutrition support, and poor calorie, along with the cystic formation, all these things, along with type 2 diabetes, uncontrolled, a brittle-like diabetes, these kind of patients can be used, a pancreatic function test can be done. But what is the rationale? How are you going to manage based upon whether the patient deserves PEP in the form of amylase, lipase, protease? What are you going to support for the patient? All these things to be taken care into account if you manage this patient. So the pancreatic function test can be done only when the patient is having suspected evidence of a malabsorption along with the chronic pancreatitis, or if you are going to suspect a genetic focus like a SPINK mutation, a trypsin mutation, along with that CFTR mutation, cystic fibrosis, so many genetic manipulations, so many genetic causes are there. So in this entity, there is the role of pancreatic function test. Apart from that, in the common scenario like alcohol, the common scenario like biliary pancreatitis, no much of role of pancreatic function test to be considered, sir.
Sir? Dr. Lakshmanan.
Sir, thank you, sir. Thank you for patient listening, sir.
Congratulations. You did very well.
Thank you very much, sir. Thank you, sir. Thank you, sir.
The days we used to give a lot of octreotide, somatostatin, I think all these things have gone now. I think
yes,
sure, you're done with the subject. I have a basic question. How does this elevated TGL, how does it cause acute pancreatitis? Number one. And now how will you bring down the triglyceride levels in those patients?
So in this kind of scenario, sir, thank you, sir. Thank you for your patient listening, sir. And in this kind of scenario, if the patient is having elevated TGL, now because the role of statins always when you're going to use is still, but we can try statin along with fibrates, definitely is may have a reasonable beneficial role. But if the patient is having severe TGL, we need to go, I mean, a very high elevation on 1,000, even if this baseline guidelines, if the patient is not going to come down, the ideal technique is lipid pheresis. So lipid pheresis can be tried, but how far it is going to be successful in many centers is still a questionable issue. But in the background of this diabetes and other complications, if the patients are going to be present, there are some newer molecules like saroglitazar, other things can be considered in the addendum profile, but all these things can be added to, I mean, we need to wait, watch and monitor. It's not been improved. Definitely it's not going to improve within a period of immediate time. So we need to give a consecutive time within slowly stepping up and stepping down. But fibrates and statins can be definitely considered along with saroglitazar can be added along with, if nothing is going to work on lipid pheresis, is the only modality. If such patients, but always we should remember that, sir, even if the patient is having only hypertriglyceridemia without any evidence of calcium, any other evidence, no structural abnormality, no pancreatic divisum, no other problems, only with this kind of presentation, if the patient is having pancreatitis, doesn't mean that the patient is having only because of triglycerides. We need to look for always a coexisting etiology, all the problems to be taken care of when you're managing, sir.
No, if it is due to only hypertriglyceridemia, what's the mechanism of acute pancreatitis?
So the most common mechanism for this hypertriglyceridemia, because of this cathepsins and other pathway activation, and it will be predisposing to mainly by a high TGL, the apolipoprotein activation. This will predispose to acinar cell injury, sir. So acinar cell injury, once it's going to set in, the proenzyme activation is going to be there. That's the most common mechanic which will be predisposing for acute pancreatitis, sir.
Thank you, Arun. Thank you for the good explanation. Thank you very much. You did a very lucid presentation. Very nice for the audience to share. And
thank you,
how prognosis? How attendance says patient is going to become all right or not? How do you? Those days we have a Ranson's criteria. Then
Ranson's criteria. Yes, sir. What you said is yes, sir. So what you said is absolutely true, sir, but the Ranson's, Apache is very cumbersome to use, because if you want to say Ranson's and all, there are 12 to 13 criteria to be taken care into account. The day one of monitoring, followed by within 48 hours of presentation. All this is, and moreover, it's very cumbersome nowadays. So bedside indicators like BISAP scoring, other things can be taken care. But always one good thing, that whether the patient is having evidence of SARS or whether the patient is not having evidence of SARS, whether the extra organ system is being involved or not, the extra organ system is being involved, or whether the patient is having any evidence of fluid collection is there or not, or whether the patient is having evidence of necrotizing pancreatitis is there or not. Based upon this, we are going to deserve the management for this kind of patients. And even only with acute pancreatitis with minimal peripancreatic fluid collection in the early phase, only with the pain management, nutrition, IV fluids and other things, without much of antibiotic support, definitely most of the patients is going to improve well. But serial monitoring has to be done, sir.
I think as you mentioned, there's not a lot of papers on Ulinastatin. But what about your personal use? Have you tried it?
Personally, I will be saying one thing, sir. There are not much of papers for Ulinastatin. What you said is absolutely true, sir. But there are many trials being given for in ARDS, septic shock, and vascular insufficiency and other things. For pancreatitis, there is few papers being reported for that. But if nothing works on, then definitely we need to go for that. And moreover, most of the centers, even in Chennai and other parts, they are being using Ulinastatin nowadays. And along with that, we can consider for 5 days. But how far this patient is going to improve, how are you going to tackle with other organ system involvement, all these things deserves a management for the setting of severe acute pancreatitis with multi-organ dysfunction, sir. But Ulinastatin will definitely have a reasonable role in the management, sir.
Thank you, Arun. Bye-bye. Thank you.
Thank you, sir. Thank you very much, sir. Thank you, sir.
Good evening, Arun, sir. This is MVS here. Nice talk. Nice talk. Did you have some water? Because you are continuously talking for last 1 hour. This is really admiring stamina and.
Sure, thank you, sir. Thank you.
And actually, see, last 24 years of my practice, I've seen many pancreatitis cases, mostly in adults only.
Yes, sir.
And, the pathogenic situation of after that acute problem solves, they chronically present with a pain which is radiating to the back, from the figure to the back. It doesn't respond to any medications, any painkillers or any medicines. We had a tough time those days and all. And then we used to subject to some anesthetic medications are injected, and also some nerve procedure also has been done.
Yes, sir.
Yeah, many things. what is the ideal painkiller for in case of acute condition as well as for a chronic pancreatitis, which
So
is the
always,
ideal?
that's yes, sir. So always in acute pancreatitis, the main problem is pain, sir, because the pain is going to activate your vagal and sympathetic. So what is the main thing? So we need to take care either by NSAIDs or by opiates. But if you're going to give NSAIDs, the problem is sometimes the patient can precipitate renal failure and other complications. But if you're going to give opiates, sometimes the patient can go for respiratory depression and tolerance like effect. So if you're going to develop, if you're going, but the best one, what you're going to try is always opiates, because opiates are more potent analgesic. But some papers have been reported even NSAIDs in like diclofenac and other things. In the background of mild to moderate pancreatitis, NSAIDs will definitely have a reasonable role. But if the patient having severe acute pancreatitis, severe presentation, so there is high potent benefit with opiates only. Sir. But if at all, if you want to combine in the management of acute pancreatitis, we can add fentanyl to that. All these things can be tried. We need to access the WHO data system of analgesic effect, but most of the centers, what we are trying, but we are not doing that when you are managing a patient with acute pancreatitis, to be very frank. But we need to monitor this patient, and if the one analgesic is not going to work on, we need to add on with second analgesic, provided the organ function has to be taken care into account. But the best analgesic in our practice is always opiates. In the management of chronic pancreatitis, always the pain will not be more common pathology. The exocrine insufficiency is the most common pathology. So the patient, rather than pain, will be having other presentations more. So if you are going to manage a pain in this kind of scenario, sometimes we can also go for EUS guided the celiac plexus block with the bupivacaine and other injections can be tried. So many modalities, sometimes, symplectomy, other nerves, so many things have been tried, but US guided block also will be valid only for the period of around 3 to 4 months. After that, the patient will be having again pain. If the patient is having persistent pain with severe exocrine insufficiency with other complications, the patient has to go for surgery, sir.
Usually, in those days, we used to manage with the initially NG tube, and then only we give water. And then the second or third day, we used to take this same amylase, whether it has come down. Then we introduce tender coconut, and then slowly carbohydrate, then protein, then comes last fat. Whether this is followed now, this regime, because now I'm not managing in that way. What is the present line?
The present line of management also remains the same, sir. But if you are this, what you have been discussing, all those things in the conservative management of pancreatitis. So in the conservative management of pancreatitis, the ideal thing is the pain management and nutrition support along with the fluid management. So what you are saying is true, sir, is accepted, but provided we need to see this kind of patients whether it is progressing to other complications, because so initial phase, what we have been done, the endoscopic interventions have not much been developed, but now the field of endoscopic interventions in the field in gastroenterology has been gone so very high, that too for a pancreatic management. So this kind of patients, we need to monitor serially whether he is having any other complications been developing based upon to carry out for endoscopic interventions, whether the patient deserves or not. But what you said, as per that initial phase management, asymptomatic with minimal symptoms, this kind of management definitely works on well, sir.
So is the patient totally should prohibit alcohol in future too, or how you'll be suggesting? Some person may ask us.
There are two main things for alcohol, sir. It is a pancreatogenic dose or a liver toxic dose. The pancreatogenic dose is always, around 10 to 15 years if you are going to consume in the unit of around 14 units per week in case of males or females. So suppose if the patient is going to be in a pancreatogenic dose, you always supposed to abstain from alcohol. That's the most important thing. But most patients will not be there. Sometimes if the patient continues to take this precipitating event, but once the problem of acute pancreatitis sets in, and even after that, if you're going to take alcohol or other things for a longer duration of time, again after for a period of around 5 to 10 years, there is high possibility for this kind of patients can go for a chronic pancreatitis, followed by, for this kind of patients can go for a pancreatic malignancy.
How common you are seeing recurrent pancreatitis?
Recurrent pancreatitis, what is the etiology we are going to deal? That's the most important. We are frequently experiencing in our centers also, sir. But recurrent pancreatitis, always we should remember there is one strong etiology cannot be ascertained, because in a period of around 8 weeks to, in a period of around 6 months, you'll be getting frequent attack of pancreatitis. So even if the patient has metabolic abnormalities, even if the patient having calcium abnormalities, suppose we should not take all these things into account for management of recurrent acute pancreatitis. Always we need to look for structural anomalies like pancreatic divisum, annular pancreas, or these things to be taken care in the management of recurrent acute pancreatitis, whether this patient is having all these pathologies there or not. And we need to do a MRCP at that kind of presentation to analyze whether the patient is having evidence of recurrent acute pancreatitis.
Okay. How about the incidence of diabetes, sir? Actually, which part of the pancreas is involved? That only matters. Am I right?
Yes, sir. Sure, sir. Sure. So incidence of diabetes in the setting of chronic pancreatitis will go for brittle, which is very, very common scenario. Around 50 to 60% of the chronic pancreatitis patient will be having evidence of diabetes mellitus, sir.
So over that enzyme supplements, whether you have to provide it for a longer time?
If the patient is having chronic pancreatitis, if the patient is nutrition deprived, if the patient is having severe fat malabsorption, if the patient is having evidence of protein malabsorption, and if they are going to do a stool test, steatocrit test, all these things shows evidence of these things, means we can give PET. But problem with PET, there are some rare complications like stricture, other things can be reported, but the cost issue is still more high. And PET supplementation, if you are going to give, means doesn't mean that the complete process is going to improve. The only thing, the nutrition process, along with, because it's a capsulated entry coated microscope, we need to give around 30,000, 40,000, one for 1 meal, and half of the dose to be given in the initial phase, followed by half of the dose to be taken in along with the meal. So we need to go around 3 to 4 times a day supplementation, which almost carries a huge amount for the patient. And but doesn't mean that only with PET the patient is going to improve. We need to take care of all other complications has to be accounted in a proper manner. But PET is having a reasonable beneficial role in the management of chronic pancreatitis.
Okay. Have you seen any worm infestation causing pancreatitis?
Frequently for recurrent acute pancreatitis, we always look for the worm infestation because ascariasis will be always predisposing some of the time. Sometimes I have seen some patient with endoscopy who present with recurrent acute pancreatitis, even the biliary tract, some patients have been reported with evidence of worm infestation. But it's not very common scenario, but case reports are still very high out there.
Fantastic. Thank you, Arun. Nice.
Thank you, sir. Thank you very much, sir.
Yeah, thanks, Dr. Suresh. Thanks, Dr. Lakshmanan. Any other question from any audience? Or rather, the participants, yeah. Last question, Dr. Arun, like when you were talking about the conservative, so when to refer to the surgeon? If you just give any kind of a practical experience.
Of course, if the patient pain is couldn't able to tolerate, if the patient is having severe pancreatic collections, if the patient is having worsening, even if the endoscopic interventions cannot be attained, or if the patient is needed for a cholecystectomy in the earlier phase, at that point of juncture, we can refer the patient for surgery. But nowadays, the advent of gastroenterology has gone very high. Endoscopic intervention most of the time will be taken care of into account.
Yeah, actually, I was coming to that, and then when to actually decide on the ERCP interventions. So, what are the factors? Yeah.
First 40 to 72 hours, if the patient is having evidence of cholangitis, we can do a ERCP intervention. But always, if the suspecting only a biliary pancreatitis, ERCP intervention not to be attempted at any point of time. So, if you're going to strongly suspect the patient is having cholangitis in the background of fever, jaundice and other phase, then we can do early ERCP intervention to prevent organ dysfunction and other complications.
Fantastic. Thanks a lot, Dr. Arun, for your lovely talk and interaction with the audience. And I must thank to all the audience, even taking out your time in a day, busy schedule, right? All of you are attached to the hospital, but still participating and attended this program for over an hour. And we'll continue to do this such type of program in the future as well. Thanks for supporting, and have a great day. Our team will be there in touch with you. Thanks, Dr. Arun, once again.
Thank you for patience. Thank you very much.
Thanks.